Hi, I'm Angela Poindexter, Integrated Marketing Manager for Roper St. Francis Healthcare. I'd like to thank you all for joining us today. This is our second round of recording for this topic. Now, Roper St. Francis believes knowledge about your health is very powerful. We have partnered with Red Hot Mamas to help you get a better understanding about your health at menopause and through your postmenopausal years. And we hope that you will find our series of programs to be informative and useful. With all that is going on around the time of menopause and all the questions and concerns we have about it, its bothersome and sometimes mysterious symptoms, we sometimes don't make our heart health on top of our list. In fact, heart disease is the #1 killer of women, and it claims more lives than all cancers combined. And once you enter menopause, your risk in heart disease increases significantly. This may be due to declining estrogen levels. Knowing your risk factors of developing heart disease, it is very important. And today, our presenter will provide you with the facts about heart disease. She will also give you some heart protection strategies. And please know these are things which you can do to significantly reduce your risk of heart disease by making healthy choices. Here's a brief overview of today's program. Our presenter today is Eileen Mulan, pharmacist and heart failure navigator for Roper St. Francis Healthcare. She will provide you with the essentials about heart health and address your questions and concerns. At the end of the presentation, you will receive information about the program and the sessions. So without further ado, I'd like to share our presenter, Ms. Eileen Mulan.
Thanks so much, Angela, for the introduction. This is take two. For those who saw take one, we didn't have any slides. So this time, it's new and improved. Maybe we'll add a little bit to our last session, but it's round two of The Beat Goes On with heart disease and menopause. So what Angela had said in terms of the importance of knowledge, that is something that can't be said loud enough or enough times. So I was looking when I was trying to decide what should I talk about. Or, when we talk about menopause, we don't think fun. So I wanted to I looked up, fun facts about menopause. So I found some fun ones. So I want to share them with you today. And things which gets back to the importance of knowledge. So classic medicine actually defined women in terms of menopause as deformed males who came closer to the male ideal after their menopause transformation. Isn't that just fabulous to know? If that weren't brutal enough, menopausal women were seen to have lost their femininity, their beauty, their fertility, and their status, and they stood at the gateway of death. I'm glad we got a little knowledge. We keep going with this for quite some time. Menopausal women were described as sour, egotistical, ugly, half-formed with coarse features such as mustaches, rough voices, and flat chests. As time went on, the diagnosis of menopause became much more specific, and doctors identified the condition through these rather questionable symptoms. So the symptoms of menopause, this was symptoms of menopause: hysteria, nymphomania, alcoholism, and kleptomania. I'm not sure we still have those as symptoms. I'm going to talk about that. In 1966, Dr. Robert Wilson, he wrote a book called Feminine Forever, where he recommended estrogen to make women who were going through menopause more pleasant to live with and not dull or unattractive. So thank goodness. The last fun fact, and the most important, was they actually did a survey in the 1980s, and they surveyed about 8,000 women ages 45 to 55, and they found that the vast majority of the women didn't really report more symptoms or poor health at menopause. But people before they reached menopause were concerned about all these symptoms. So we're going to talk about a whole bunch of stuff today. What we are going to talk about the facts. So kleptomania, nymphomania, and alcoholism are not symptoms of menopause. All right, so we're going to get right into it. So today we are going to talk about women and heart disease.
Eileen,
Accent statistics.
your mic is got a lot of static. Do you have something rubbing against it on your ears? Is it your hair? Are you using the laptop or your earbud?
Yeah, I'm using the laptop. Can you hear me better now?
Yeah, I don't know what it was.
Maybe I had my paper on it.
Oh, that could be it.
That
Okay,
could be it. Okay.
Yeah. so we're
So
good.
do you
Okay,
want-
you start.
Do you want to redo it from the beginning? So you can hear-
No, because I can get all this, well, our conversation edited out.
Okay.
Yes,
So, okay.
so you can start.
I'll start off with facts and statistics. So today we're going to talk about women and heart disease, facts and statistics, what is heart disease, menopause and heart disease, hormone therapy in your heart, ways to reduce heart disease, and some of the resources we have. So important, we're going to do this in two phases. We'll talk about menopause, we'll talk about heart disease, and then we'll kind of bring them together. So menopause is defined as the end of menstruation. It confirms that you haven't had your period for 12 consecutive months. At menopause, we no longer ovulate and our ovaries produce significantly less estrogen. Menopause occurs naturally or can be induced surgically by removal of the ovaries or other medical treatments. Premature menopause is a term we use when women go through menopause before the age of 40. All right. Heart disease. So heart disease, about 30 million Americans in 2018 were diagnosed with heart disease. It's the leading cause of death for both men and women. And every year, about 650,000 Americans die from heart disease. So like 1 out of every 4 deaths. What I think a lot of people are unaware of is that women are just as likely as men to have a heart attack. I think we think it's maybe 60-40, 70-30, but it is not. Women are just as likely to have a heart attack as men. The concern when it comes to us women is that women face a 20% increased risk of developing heart failure, which is something that I'm very passionate about, or dying within 5 years after their first severe heart attack compared with men. And I think that's impactful to know that. 90% of women have 1 or more risk factors to developing heart disease or stroke. All right, we're going to go through some of those. So like I said, heart disease, leading cause of death for women, killing about 1 in every 5 female deaths. When you look at breast cancer, like Angela mentioned before, she talked about all cancers, but specifically for breast cancer, 1 in 31 American women die from breast cancer each year. When we talk about heart disease, we're talking about 1 in 5. Not sure everybody is that aware of that difference in those 2 numbers. We do a lot of talking about breast cancer, which is super important, but maybe we need to have more conversations about heart disease as well. I said this before, fewer women than men survive their first heart attack. So let's talk about some of the diseases we see. What heart disease do we see, right? We see coronary artery disease. I think probably most people would think about, right? Heart attack, essentially. Congenital defects, diseases of the heart muscle, which is my favorite topic. Arrhythmias, heart valve disease, and heart infection. All right. I love this image because we wonder why women don't, maybe we wait for care. Maybe we don't recognize the signs and symptoms of heart attack when we're looking at heart attack symptoms comparing men versus women, right? So when we look at men's symptoms, they're the ones we think of, right? That crushing pain, jaw, neck, or back pain, nausea and vomiting, shortness of breath. I think most people could probably come up with those real quick. With women, it's a little different. There are 8 symptoms that we can potentially see. So nausea and vomiting, yes, same as males. Jaw, neck, or upper back pain, which is a little bit different. Upper back pain, chest pain, but not necessarily always present. Pain or pressure in the lower chest or upper abdomen, right? Shortness of breath, fainting, indigestion, and extreme fatigue. So during menopause, what's the challenge is, you know, we're losing our hormones, so we're a little bit tired, right? So we see fatigue. We might be a little nauseous every now and again, and you know, we write that off. It's not important. And the same thing holds true with indigestion. You know, we just kind of write these off like non-important things. That's probably nothing. When we think about heart arrhythmias are, you know, fluttering in your chest. AFib is probably one you've heard a lot on the TV because we have a lot of medicine that helps prevent stroke when you have AFib, right? So fluttering in your chest is a symptom of one of those abnormal heartbeats. Racing heartbeat, so going real fast, what we call tachycardia. Slowing the heartbeat down, which would be bradycardia. Chest pain or discomfort, shortness of breath, lightheadedness, dizziness, fainting or near fainting. Fainting is probably one of the bigger ones, along with that tachycardia or fluttering in the chest. Symptoms caused by heart defects. This is really most often diagnosed in childhood. So I'm not sure we see a lot of it as we get older, but there is still a degree of these. These symptoms include for heart defects, getting short of breath during exercise or activity, easily tiring during that exercise or activity, or swelling in the hands, ankles, or feet. All right. Cardiomyopathy, this cardio meaning heart, myopathy meaning muscle. So heart disease can also, symptoms of a diseased heart muscle or cardiomyopathies, that's breathless with activity or at rest. Swelling of your feet, legs, ankles, fatigue. When we think of heart failure and cardiomyopathy, we think of heart failure. Fatigue is the big one, swelling is a huge one. Irregular heartbeats that feel rapid. A lot of times with our cardiomyopathies, we see AFib, so we may see arrhythmias and cardiomyopathies together. We see, again, dizziness, lightheadedness, and fainting. And in the very early stages, you might not have any symptoms. All right. Endocarditis. These are symptoms caused by a heart infection. Fever. When we think infection, we typically think fever, or most times we do. Shortness of breath, weakness or fatigue, swelling in the legs or abdomen, changes in your heart rhythm, dry or persistent cough, skin rashes or spots. So I think with all of these heart diseases, if you're short of breath, if you're fatigued, if you have swelling, we need to think about maybe this is our heart. Maybe it's not, I ate a big salty meal, I ate some Chinese food last night, and I'm just a little swollen. Maybe we need to start thinking about maybe something else is going on. Okay, back to our valvular problems, back to our symptoms of heart disease. Fatigue again, shortness of breath, irregular heartbeat, swollen feet or ankles, chest pain, fainting. So it's very similar for a lot of these. That's why cardiologists, it's important to see a cardiologist should you have these. Because they're hard to differentiate. I think I said shortness of breath 17 times, right? When do we seek medical care for these, right? Chest pain, pressure, tightness, we definitely need to call 911. That neck, jaw, shoulder, upper back pain, or abdominal discomfort, shortness of breath, nausea, vomiting, sweating, lightheadedness or dizziness, fainting, unusual fatigue, and indigestion if it's really not going away. We always want to call 911 when we're having these symptoms, and we don't want you to drive yourself to the emergency room unless you don't have another option. And I feel like 911 always is an option. All right. So getting back to menopause and heart disease, putting them together, right? I'm going to start from the bottom of the slide and move up. In young women who've undergone early or surgical menopause who do not take estrogen, their risk for heart disease is higher, all right? Which we're going to talk a lot about that because to me, it sounds like, oh, if they don't take estrogen and their risk for heart disease is higher, maybe they need that estrogen back. So we're going to talk about that. Once women reach the age of 50, so we start losing our estrogen, about the same age of natural menopause, the risk for heart disease increases dramatically. Once again, we're thinking, okay, estrogen is the answer. After age 50, nearly half of all deaths in women are due to some form of heart disease. Back to estrogen is the answer, right? It's not. Give you the answer to the test. It's not. Risk differs for women who have early natural menopause or primary ovarian insufficiency. If you stopped having your periods before age 40, you have a different set of heart and blood vessel and cardiovascular health risk compared to somebody who reached menopause closer to the, I shouldn't say normal, I don't love that word, but the average age of 51, okay? So when I think about that slide, I really think, when we go back to it, I kind of think, well, this is the rationale where we started to think, is estrogen the answer? And so we did some trials, the big studies to see, is that true? Is estrogen the answer? All right. Things that put us at even greater risk of heart disease. Like I said, we're going to talk about heart disease risk factors. Family history of heart disease, rheumatoid arthritis, lupus, essentially inflammatory diseases, being overweight or obese, having an unhealthy diet, being physically inactive, drinking too much alcohol. There are cardiomyopathies that we see with that. Mental stress and depression, huge impact on heart disease. Smoking, high blood pressure, high cholesterol, and high LDL or bad cholesterol. Diabetes. We're going to go through these one at a time, but not necessarily on this slide. What I wanted to say about smoking, smokers, and it's there, smokers are 2 to 6 times more likely to suffer a heart attack than non-smokers. What I think can be impactful for those listening, if you're a smoker, at 1 year, if you smoking cessation, if you stop at 1 year, 1 year after you stop smoking, we know your risk of coronary disease and heart attack are reduced. We know 15 years out from when you stop smoking, your risk of coronary disease is equivalent to a non-smoker. So that's why we need to stop today, right? Because we want time on our side. So if you stop today, 15 years, you have the same risk as somebody who is not smoking, all right? Mental stress and depression, especially in this time period now where we see, there's a lot going on in our world between the pandemic and all different types of issues. Even if we just focused on just the pandemic, people being isolated and alone, people struggling with, mental stress and depression, addiction issues. So this one, really a concern. We actually have a cardiomyopathy, which you probably have heard of. You've probably heard of broken heart syndrome, which is what we call Takotsubo. It's a cardiomyopathy, and it's really as a result of true stress and depression. All right. Inactive lifestyle, of course, is a risk factor. Menopause, obesity, high blood pressure. And I'm going to touch on these in the next few slides. Diabetes and prediabetes, I don't talk about them in great length in the slides to follow, but I will say, I like to think of it like this, right? When we think about diabetes, and I hope there are no endocrinologists listening to this, but when we think about diabetes, if we were thinking simply, right? I like to think of those red blood cells, right? And if we're thinking about what a hemoglobin A1C is or what diabetes is, it's essentially we got a lot of sugar floating around on these red blood cells. So if we're thinking about heart disease and we're trying to get these thick, sticky, gloppy red blood cells all the way to the feet, it's a little more challenging to do if they're like molasses compared to if they're more like fruit punch, right? So that's where the vascular part of diabetes is such a challenge. And then we think if we don't get enough blood flow to the heart, it's a challenge. So diabetes plays an enormous role in cardiovascular disease. Unhealthy diet goes hand in hand with, diabetes, high blood pressure, and obesity. We're going to talk about diet extensively coming up shortly. And just a family history of early heart disease is a risk factor for developing heart disease. All right. So how do you know if you have high blood pressure? Now, I know you can read your slides, so I'm not going to read it to you, but essentially most people, I'm assuming most people are on this call who are listening to this, go to the doctor. You always get your blood pressure checked when you go to the doctor. They're going to assess if your blood pressure is high. So let's just say what is normal blood pressure? Normal blood pressure is blood pressure of 120, that top number, the systolic number, over 80, which is called the diastolic, which is the bottom number. We get concerned when it is greater than 120 over 80, okay? High blood pressure is, if it's greater than 140 over 90, we define that as high blood pressure, okay? So in the heart failure world, we really like, our definition is really less than 130 over 80. That's our number, that's what we like. High blood pressure, though, being defined is 140 over 90. And depending on what your risk factors are, that number may change a little bit. But I'd love everybody to be at about 120 over 80. Can we get that done? I don't know. If this talk gets it all done, I'm going to be super excited. How often should I check my blood pressure? I really think that depends on if you have high blood pressure. That's very different than if you've never been diagnosed with high blood pressure. And if you don't have any cardiovascular risk disease, any risks, going to the doctor and getting your blood pressure checked is probably fine. I think most people, or a lot of people, not most, but many people have these watches. You can find out what your blood pressure is just by wearing a watch. There's home blood pressure monitoring systems which are available. So there's a lot of ways. I mean, access to care nowadays is very different than a long time ago. There's blood pressure monitors, at every CVS, every Walmart, wherever there's a pharmacy, Publix, Care Cedar, wherever you go to, get your prescriptions filled, there's usually a blood pressure cuff, so you could check it there. What can you do if you have high blood pressure? This, to me, is one of my biggest questions, is talking about blood pressure. Because, everyone loves a story. This is not the best story, but it's a story, so you'll remember it. So, I had a 39-year-old patient, handsome guy. That's the important part of this. Came in, he was diagnosed at 39 with high blood pressure. And he didn't take it serious, He was like, I work out, I'm in good shape, I eat pretty healthy. And so he didn't go on his high blood pressure medications, And so 3 years later, he comes into the hospital. And he now is on dialysis because his blood pressure, was pumping away so high that he essentially never gave enough blood to those kidneys, and they shut down. And so now this really young guy, now 42 years old, who was working 16-hour shifts, working at a 5-star restaurant as a bartender, making tons of money, now really can't do that kind of work. It's just, he's got to go to dialysis 3 times a week, and it affects his life, changed it. And he said to me, I wish I knew now. I wish I knew then what I know now. He just didn't realize the importance. And I think it's important for all healthcare workers who deal with, I don't care if you're a pharmacist or a nurse, or maybe you're, the medical assistant at the doctor's office. The importance of taking your medicine, it really, I can't even speak to it. It's super important. So when we think about high blood pressure, medicine's important. Yes, very important. The other piece, and for my gentleman that I was talking about, he had familial hypertension, or, it was as a result of his family. We do know 70% of high blood pressure can be controlled with lifestyle. So a lot of times when when you go to the doctor and they say, your pressure's up a little bit, they may say initially, like, listen, we want you exercising and eating right, and we're not going to put you on medicine yet, but we want you doing everything right. They mean that, okay? They're not saying that because that's the right thing to say. We know the evidence supports that 70% of our blood pressure is as a result of what we eat and what we do. So we need to do a little bit better eating, and we need to do a lot better exercise, okay? Meds only fix 30% of the problem. Okay, so they're important, yes, especially for a patient who has, uncontrolled hypertension. Medicine is always important, but so are the other pieces, and I think we negate the other pieces. It's kind of like when people have coronary and cholesterol issues, we put you on a statin, and they think they can eat French fries. That's not how this works, right? We got cholesterol in there, we're not trying to add more in it. When we have high blood pressure, we're not trying to increase it more. So really, lifestyle and diet really play a huge role in blood pressure. In take two, I did not say this in take one, but I like to think of three things when I think of medicine being a pharmacist. Cost, right? For anyone listening, if they prescribe you something and it's too expensive, we don't just, accept that. There are other options. We have many options. It's important you relate to your provider. I can't pay for this. It's not, if we're trying to figure out keeping the lights on or getting gas, or with the pandemic, maybe we're not working, maybe we can't afford whatever this one is, but maybe this one over here is reasonable. We need to make sure we have a conversation with our provider. This I can't afford. There are many options, okay? The other thought is really, so cost is important. The other piece is really commitment. And what I mean by that is maybe we don't realize the impact that blood pressure has on us. I feel like there was probably a test or a questionnaire sent out to everyone, and they were given the answers. And because anytime I ask someone, what is our concern if we have high blood pressure? Every single patient that I've ever talked to says stroke. I'm like, okay, all right, that's true. That is absolutely true. Stroke is a concern. The other concerns also are our kidneys, right? Dialysis. We want to make sure we're getting enough blood to those kidneys. So cost is one concern. Commitment, understanding our disease state. Maybe we need to explain to you why this is important. And then the last one is concern. Maybe this medicine is causing side effects that really aren't working for you. Maybe we need to talk about that. Maybe that beta blocker they put you on is making you so very tired. Well, maybe we need to switch it up, okay? So having that conversation with your provider is super important. How do I know if I have high cholesterol? There really are no signs and symptoms of high cholesterol. Really, we need to do a lipid panel or a lipid profile to check, draw some blood, see if we have high blood pressure, see if we have high cholesterol. They're going to look through those numbers and find out there's different ones. There's an HDL, there's an LDL, there's a total cholesterol. So HDL is the one, I like the word that it begins with H because we want that one to be high. That's our good cholesterol. I'm really hoping our HDL is high. My counterpart that I work with in the clinic, her HDL is really high. It's like 88, and I wish I could have HDL that high. But so when you think of HDL, that's our good one. We want it to be high. LDL is the bad one. We do not want that one to be high. When we think about total cholesterol and what a desirable number is, really we want a total cholesterol less than 170 and an LDL, or the bad cholesterol, less than 110. All right. Your doctor for high cholesterol is definitely going to talk about medicine and lifestyle changes and eating and exercise. What we eat plays a huge role in cholesterol, right? So, and I think with McDonald's and Chick-fil-A and Wendy's and Arby's and Zaxby's and all of the fast food restaurants that we have, I don't think in the 1950s when they started creating these, I don't think they realized what it was going to do to our society, right? We're getting heavier and heavier, and we're getting more and more cholesterol. So watching what we eat is super important, all right? And we're going to talk about diet in a minute. It increases our level for our risk for heart disease and for stroke. So that's why we're concerned about high cholesterol, all right? So what can we do to reduce our risk of heart disease? Quit smoking. Absolutely. Need to do it. Roper St. Francis has a smoking cessation program. Many facilities do it if you're not in the Roper area. But important. We have tactics and ways to actually quit smoking. It's hard. It's addictive. It's not easy. If it were easy, no one would smoke. Everyone has seen those commercials where they, where they have the patients that, have had tracheotomies or, who have had surgery and parts of their jaw and face removed. So we know it's not good for us. If you need help, there's resources out there to quit smoking. Exercise regularly. The American Diabetes Association really shoots for 150 minutes of exercise per week. So I like to say 30 minutes a day, 5 days a week. We also like to put in some resistance training, a little bit of weight training is important. But before you do that, make sure you're fit to go ahead and exercise. Maintaining a healthy body weight, we're going to talk a lot about that. Eating a healthy diet, managing your stress, limiting your alcohol. If you drink more than 1 drink a day, we need to cut back. I feel like my partner and I call it the COVID cirrhosis, because we've got a lot of people drinking more than they ever have before. So addiction is a huge problem during this pandemic and just in general. So we really want to make sure we're limiting how much we drink. There are cardiomyopathies that are associated with drinking. Dilated cardiomyopathies can be alcohol induced, so we want to be careful with how much we are drinking. I always like to bring this up. I had a 25-year-old kid who had finished college, and he said, I wish somebody would have said that he had dilated cardiomyopathy, a really weak heart, hardly squeezing. And he said, I didn't know that alcohol could cause a weak heart. I thought alcohol just hurt your liver. And I think most people think that, but it really is a cardiotoxin and can hurt your heart. But everybody does it, so they think it's fine, but really we need to limit our alcohol consumption. Managing our health conditions, like we said already, our blood pressure needs to be managed, our cholesterol needs to be managed, and our diabetes needs to be managed. So these are tips and tricks to reduce our risk of heart disease. So, let's make exercise fun, right? Exercise doesn't just have to be like, I gotta go be on the treadmill. I mean, we gotta take the clothes off the treadmill so we can use it, right? No, I mean, we got other things we can do. You can play outside with the kids, take the stairs. I wish my husband was seeing this. Do household chores. Let's say that again. Where's my husband? Do household chores. Where I'm the only one participating in that fun exercise activity, right? Cycle to work. For some people, that's not an option. If it is, great. If there is public transportation in your area, getting off a stop early so you can walk, great idea. Okay. So, I think everybody knows exercise is healthy, right? It does reduce our risk of heart disease. But what can it really do? It controls our weight and reduces our stress, produces endorphins. Like I think I said 15 times, it reduces our risk of heart disease. It's going to reduce our risk of cancer, diabetes, and depression. Osteoporosis protection, especially for our menopausal women. Enhances a stronger immune system. And back to our good cholesterol, we want it high. It increases our good cholesterol. How do we get started? Like I said, we don't want to go from being sedentary to running a marathon. Maybe we get a checkup, make sure we use, my sister-in-law always says, treat your feet. Let's make sure we got good shoes to do our exercising. Staying hydrated, important. Especially, we're in Charleston. I'm not sure where everybody out there is. It's real hot here, real humid. So plenty of water for those patients, for those people who are exercising, especially if it's outside. We want you to exercise on a regular basis. Like I said, the American Diabetes Association endorses 150 minutes of exercise a week. I want to say that ACC, I think the American Heart Association endorses 45 minutes of exercise a day, if possible, anywhere from 30 to 45. If you need instruction, get it. There's, a bunch of places like the Y. A lot of people have rec centers near them. Keep a fitness log is a great idea. And use your family and friends for support. Get them out there exercising as well. Okay. So I went to a trainer, and you get assessed, and they essentially are like, you're really kind of fat, you're really not flexible. So he actually said to me, so my husband bought this for me for Mother's Day. I really do love to exercise, so I was super excited. So I know that sounds like a terrible present, but I promise I was excited. So we want you to do, when we think about an exercise routine, warm up and flexibility is super important. My trainer said you are the most inflexible patient, not patient, customer, client, I think they call client I've ever had in my life, because I really am terrible at this. So important to warm up so we don't pull something, and we want to make sure we're stretching, right? So about 10 to 15 minutes of that, doing some muscle strength and endurance, some calisthenics, so some weight training is important. Planking, for those who know what that is. So 15 minutes of that, and then 20 minutes of cardiovascular or aerobic activity. My thoughts are Women are real good at this cardiovascular aerobic activity. It's the muscle strength and endurance training, like weightlifting. I'm a little intimidated to go back there with all the weights in my gym, but I've been doing it, so I'm proud of myself. And then a little cool down and stretching for 5 to 10 minutes. That gives you about 60 minutes of exercise. A topic that is so very near and dear to my heart, weight and obesity. So more than 2 in 3 women in the United States are overweight or obese, right? When we think about obesity, we got to have a higher blood volume, right? We need a higher blood volume to get blood everywhere. We got a heart that has to work harder. It's working overtime, and we potentially see heart failure. I wish I could have sent out a poll to say who thinks, who knows what an overweight person is, because it's more shocking than you think. So for me, a BMI of 25 to 29.9 are considered overweight. So I don't know if you can see me. My BMI sits right at about 25. I'm overweight. Working on it real hard, going through menopause for all my people out there. Going to turn 51 this year, already in menopause, and I am struggling. I have never been this heavy in my whole life. I weigh 155 pounds. I can't believe this is going to be on YouTube and I'm saying that. And I am fighting with everything I have. I exercise, I'm trying to eat healthy. So we're going to talk more about that. But to me, that's what's shocking is a BMI of 25 to 29.9 are considered overweight. And women with a BMI of greater than 30 have obesity. So here are the definitions, right? A BMI or body mass index. The way they calculate this is they take how tall you are with how much you weigh and kind of come up with what your BMI is. Now, if you're super fit, if you're running marathons every day, this number may not truly be reflective for you. There's a lot of debate on this. We're not talking about that. I'm hoping you're just our regular people who are trying to do everything right, but maybe don't run marathons every other weekend. Okay. So when we think about a body mass index, below 18.5 is underweight. Between 18.5 and 24.9 is normal weight. I sit right at 25. I'm in the overweight. So 25 to 29.9 is overweight, and 30 and above is where we see obesity. So I love the image on the bottom of this slide where it's showing 3 different people with 3 different heights with all the same BMI. So, height and weight really truly affect what we look like and what we're classified as. All right. Sorry. Here's where we talk about diet, right? So 8 steps to prevent heart disease. Control your portion size, right? Eat more vegetables. Select whole grains, limit unhealthy fats, choose low fat and protein sources, reduce your sodium. So when I think about this, everyone asks me in the heart failure clinic, what's the best diet? There's Jenny Craig, there's Weight Watchers, there's so many different diets out there. The American Heart Association, the Mediterranean diet is probably one of our best diets that we have. Because it focuses on these things where we're eating more vegetables and fruits, we're eating healthier fats, right? So when I'm not a dietitian, but when I think about fat, we'd rather your fat come from a plant rather than an animal. So butter is worse than say olive oil, all right? And that's what the Mediterranean diet really focuses more on olive oil. When we think about sodium, processed food, McDonald's, Burger King, all those things, if it comes in frozen, there's a reason they freeze it. They've got to put some salt in it to keep it tasting the way it does. The same holds true with things in the grocery store that come in cans and boxes and jars. There's always sodium in them, right? We want to make sure we're doing a low sodium diet for multiple reasons. Why? We know low sodium is going to decrease our blood pressure. We know low sodium is going to help with those patients that actually do have, some heart failure. So low sodium is super important. The average American diet, and there is a diet called the SAD diet, which is a terrible name for a diet. However, I didn't know what that was, and I went to a talk recently, and they talked about this SAD diet, and I thought, gosh, who wants to be on the SAD diet? That's a terrible name. The SAD diet is the standard American diet, and in the standard American diet, we eat like between 5,000 to 6,000 milligrams of sodium per day. That's horrible. When I was preparing for this talk, I Googled Starbucks. You know, I just wanted to see how many calories are in those drinks, right? So the best Starbucks drink is the vanilla latte, and there are 250 calories and 35 grams of sugar in that drink. So I think we're doing a lot of eating out and a lot of extra calories that we really don't need. We need to reduce our portion sizes, right? We got pizza slices that are this big. I mean, I'm originally from New York. Those slices are giant. We're eating too much, and we're eating too much of the bad stuff. So we know we can prevent heart disease, but let's reduce our portion size, right? Obesity and what you can do with it. I don't work in bariatric medicine, but we do know changing your diet's important. If you decrease your everyday calorie consumption by 500 calories, so our calorie deficit, we want to decrease our calories per day. If you reduce your calories by 500 each day, and you multiply times 7, that's 3,500 calories. That's enough, that's 1 pound. So if you decrease your calories by 500 calories a day, over a week, you'll lose a pound. So if you double that, you lose 2 pounds in a week. So it goes on really quick, but comes off really slowly. So if you can decrease your caloric intake, your weight is going to reduce, okay? There's no mystery in that, right? There's no magic. You know, it's not all of our diets. We have Atkins diet where people are eating, you know, or keto diet, people are putting bacon and sausage and cheese and they're eating no carbohydrates. You know, let's just use a little common sense. Let's decrease our calorie intake, all right? Add physical activity. Why physical activity is going to burn some of the calories? Medication. There are medications we do use for obesity. That would be something probably that a bariatric physician would prescribe. They're not great. They work to a degree if they can get our people jump started to lose some weight, but they have side effects and they're challenged, they're expensive. There's a lot that goes on with those medications. And really, the other piece of bariatric medicine is surgery, which you may know people who've had excellent results. All right, so getting back to, so we talked about heart disease and, you know, that piece. Now we're getting back into menopause therapy with hearts, right? So there was this women's health initiative that was done, and it was the largest controlled trial to date. So I don't know who my audience is. So when we talk about a trial is, you know, we want to make sure that we compare things to see if they really work, right? So, you know, a lot of people think cinnamon works if you're diabetic, or they think some of our natural products work because their friend tried it and this is what happened. And that's possible. And that could have happened. However, what a trial does is it says, can we do it again, right? So if it's repeated over and over, will we see the results on a regular basis, right? That's what a trial does. So what they found in the Women's Health Initiative, that there was a small increase in heart disease in postmenopausal women using both estrogen and progesterone therapy. But for women in the study that were using estrogen alone, there was no increased risk of heart disease, all right? Here's probably the most important part of the talk. All of this is dependent on who you are. So the risk of heart disease to an individual taking hormone therapy is low, meaning you getting heart disease as a result of taking the therapy is low. But we do not use hormone therapy to prevent heart attacks. And we do not use hormone therapy if we've already had an attack. So we call it primary and secondary prevention. So if you've had a heart attack, we do not put you on hormone therapy. If you want it to prevent a heart attack, it does not work. So we do not put you on for that reason. Hormone therapy plays an important role in our menopausal women, but not in prevention of cardiovascular disease, okay? So remember before we said, gosh, when we were looking, it seemed like those young people did really well. I did not do well without their estrogen. And then when we took away the estrogen, or, you know, we saw an increased risk of cardiovascular disease. So we thought estrogen was the answer. when they studied it, they found out that was not true, all right? So your individual risk of developing heart disease depends on many factors, including your family, your personal medical history, and your lifestyle, okay? So you need to talk to your doctor about your personal risk. If you're at low risk of heart disease and you have menopausal symptoms that are significant, hormone therapy is probably an option for you to consider. Hot flashes, if you're struggling, I mean, that's where we see hormone therapy extremely important. We also know it can potentially, with those hot flashes, they're very bothersome for women. And if it comes to that, you do not need to suffer. If you don't have the risk factors, there's no reason when you talk to your doctor that hormone therapy couldn't be considered in the early stages of menopause for those women who are between the ages of 50 to 59. Okay. So menopause hormone therapy risks, they vary. It depends on whether they're given with or without progesterone, if you're on estrogen, your current age, your age at menopause, the dose, the type of estrogen you're taking, how you take it, whether it's a pill, a patch, or a vaginal cream. And then other important risk factors. I mean, this is all individualized. If you have a risk of breast cancer in your family, just kind of what your family medical history is important. All right. Like I said before, and I think this is the most important slide we have. Menopausal hormone therapy should not be used for the primary or secondary prevention of heart disease, meaning it doesn't help prevent the first one and it doesn't help prevent the second. So if you haven't had a heart attack, it's not going to prevent it. If you have had a heart attack, it's not going to prevent a second. Okay, so we do not use it for prevention of heart disease. What we do use it for is for those women who are at an acceptable age, relatively young, which would be me, since I'm 51, and this is relatively young, is up to age 59. So I am extremely young, obviously. So up to age 59 or within 10 years of menopause. For those women, healthy women who are bothered by moderate to severe menopausal symptoms, this is who needs it. You're a candidate for this, okay? Like I said, hormone therapy should be individual, based on your risk-benefit ratio. Heart-healthy lifestyles and other strategies are needed. I mean, it's important that we do all the other things as well. There is no magic pill that fixes heart disease. There are some things we need in terms of medicine to help us, but there are the other pieces, and I think we don't put enough emphasis on exercise and diet, right? Our society, we're going out to dinner all the time, we're drinking tons, we're not eating good stuff. We've got, every corner has some form of fast food. We're jumping in the car. Years ago, no one jumped in the car, right? We didn't do that. Everybody walked everywhere. Maybe your family only had one car. So some of the reasons as to why we have more of a sedentary lifestyle than we did, technology, clearly. I mean, we're all sitting here. What I did want to say, I wanted to end with estrogen. When I looked up estrogen and what that word means, right? Estrogen is derived from the Greek words oistros, which means mad desire, and genin, which means to produce. So maybe at age 60, we are done with the mad desire to produce, and maybe we don't need any more estrogen after that time period, right? I mean, I got 3 kids. I'm not in the mad desire to reproduce anybody else. I got 3, good to go. So with that being said, I'll take any questions that anyone may have. Really enjoyed learning about all this in terms of just a refresher on menopause and hormone therapy. On June 22nd, Dr. Elizabeth Richard is going to go into more of the actual hormone therapy. So I know this talk was kind of an overview of heart disease. We didn't talk a lot about medicine in terms of specifics, like estradiol patches or using, drops or pellets or ointments. Or creams. We didn't talk about all that. But Dr. Richardson's going to cover that in the next series, which is on June 22nd. Thanks so much for your time.
Thank you, Eileen. That was great information. So just to end the day, the session, I did want to go back and talk about obesity medicine. Roper St. Francis does have a non-surgical weight loss program, obesity medicine. We have Dr. John Cleek, and we also have a bariatric program with doctors Mitchell and Thomas. If you want more information, you can find that on our website. Or if you have questions about it and you want me to get you some more information, please feel free to email me. And if you've seen this in round 1, this is round 2. So if you have questions for Eileen, please email them to me and I will get them to her. We will get any questions that she can't answer to our congestive heart failure medical director, Dr. Pinto, as we did in the first round. So feel free to email me. I am here. This will actually go out to everyone that registered. So you may not have seen the first round, but now you have the final and the second round of the recording. So I thank you for participating and being patient with us for our May session. And I do have resources that I could send you via email, as well as questions to ask your doctor. So if you have not received those, if you registered and was not able to attend the May session, I can get those to you as well. So I thank you. Please fill out the post-session survey. That will be very helpful to help us moving forward in 2022. Hopefully we'll be able to partner with Red Hot Mamas again. So I thank you and have a wonderful evening.